Well, fentanyl is a very potent synthetic opioid that is traditionally used in pain management and anesthesia.
So fentanyl is an opiate, just like morphine and heroin and codeine and hydromorphone. But fentanyl is a much more potent opioid and has a very high affinity for the opiate receptor.
It's a pharmaceutical. It's legal with a prescription. Typically, it's normally found in transdermal patches, lozenges, or even a nasal spray. It's typically anywhere from 50 to 100 times more potent than morphine and 15 to 20 times more potent than heroin.
Fentanyl is a medication that's been around for many years, many decades actually. And it was a medication that was very highly controlled, and a lot of people didn't have access to it.
I think the first instances that we started seeing with fentanyl were back in 2010, 2011. At that time, we saw a number of maybe some patch issues coming up, people diverting patches, smoking patches, taking the gel out of them, and or getting lozenges.
In the past, when people were taking fentanyl, they knew exactly what they were getting, they knew how much they were using. But even people who abused fentanyl in the past really had a high rate of death and overdose as well.
I believe we started to see more of a trend with illicit fentanyl back in 2012, and specifically a move from 2012 to 2013, quite possibly as a result of the discontinuation of oxycodone and the creation of OxyNeo.
Definitely time-wise, the disappearance of OxyContin was very much related to the appearance of heroin and now fentanyl in the Alberta black market. OxyContin was initially the drug of choice, particularly amongst recreational users, young users in high school from upper middle class families. And on the street you would see injection use of OxyContin as well. When that went away, something needed to fill its void. And while we hadn't seen heroin for a long time in Alberta, because we're inland and heroin usually lives in port cities, we started to see heroin come in at a very cheap price. And it seemed almost like a door crasher type of price to get people to move from OxyContin to heroin. And then you'd see heroin's price creep up a bit as well. The illicit fentanyl came up looking like Oxy 80s, right? The same green color, the same stamp of 80. And it would stand to reason that it was masquerading as Oxy because that was the previous drug of choice, and this would be a way to take over some of the heroin market. So I think that there are some of these things that were going on in the black market that are probably predictable phenomena when OxyContin went away.
What's happened now is you have illicit fentanyl manufacturing occurring. So this is not medication-grade fentanyl that's out on the streets. This is something that's often made in a lab or in some illicit way. So when people use this, they never know exactly how much fentanyl that they're getting. Even from pill to pill, batch to batch, it's really difficult to understand how much of this potentially lethal substance is in it.
The majority of our fentanyl is coming from China, as there's no regulation on fentanyl in China right now, so somebody could certainly go ahead, contact a chemical company, and have it shipped direct to Canada or the US. And specifically, it'll just be the powder that's brought to Canada, at which time it will then be dispersed to the drug manufacturers, who will then utilize mixing machines, tableting machines, and counters, and then they'll disperse it as that specific tablet. The amount of fentanyl that goes into a tablet is realistically 2 grains of salt. Now you have to disperse that 2 grains of salt into that solution so that it's uniform throughout. And because they're not pharmaceutical companies that are doing it, at times when they're mixing the fentanyl with their binder and their cutting agent and creating the tablets, there can be what's called a hot spot. So I equate it to, or if you think about it in layman's terms, creating a batch of fentanyl pills is like creating a batch of cookies by a cook. Certainly the same ingredients would go in it, the same amount of ingredients, the same chocolate chips, flour, butter, and oil, or whatever they're using. However, when they're making each cookie, not all the same amount of chocolate chips go into that cookie. 2 milligrams of fentanyl can cause overdose and death. So typically what we're finding is that each tablet will contain 1 milligram, but as I said before, as it's measured in micrograms, that 1 milligram is 2 grains of salt. Who's to say you don't get 3 grains of salt?
So while pharmaceutically you'll see fentanyl that's in a patch and we know what the dosage is, we don't know that when it's produced in a clandestine lab. We also don't know that it's actually fentanyl. So you'll see some fentanyl analogs that would be different in some very significant ways in terms of potency, in terms of how long it takes to metabolize, and therefore how long it's active in the user's system. So those are some reasons why the street fentanyl is unpredictable.
We haven't even seen all the different forms of fentanyl that are out there right now. There's forms of fentanyl out there that are much more potent than just straight fentanyl.
The illicit fentanyl we're seeing is often mixed with other things. So, and often it's being sold as other things. So for example, it's being sold as fake oxycodone, even fake Percocets, even other medications as well.
But the other concerning thing is the drugs that tend to come along with the illicit fentanyl. One of them that we're seeing on the streets right now commonly is called xylazine. And xylazine is a drug that's used in veterinary medicine to anesthetize large animals like horses and cattle for dental procedures or for castration even. The challenge is that it doesn't respond to the antidote to opioids, which is of course naloxone. And that puts us in a scary situation because it means that some of these overdose or toxicities can't be reversed with just naloxone.
So we have seen it with methamphetamine, we've seen it with heroin, and we typically see it, I would say 90% of the time, with caffeine. Drug producers will utilize those substances in order to create their drugs. The xylazine was used as a tranquilizer in veterinary medicine, so it's quite possible that they're looking to bolster their effects of their product as well.
The major dangerous situation here is that from batch to batch, pill to pill, you have no idea what's in this substance. You don't know the strength of fentanyl in it, and that's what makes it so dangerous. Every time somebody uses it, it's like Russian roulette.
Most opioid overdoses can take up to several hours for it to actually to go from phase to phase. So the person starts to breathe very slowly, their heart rate begins to slow down, and sometimes you even hear a sort of snorting respiration. So what's happening, of course, is the heart is beginning to slow down, the breathing is slowing down, and then eventually, over a period of time, the person actually stops breathing and dies.
The earlier signs are that the patient will go on the nod and be unresponsive to stimuli, whether it's voices or whether it's somebody rubbing their chest or what have you. That might be an early sign that this is somebody who's about to be in some serious trouble.
Pay attention to the signs of an overdose, pinpoint pupils, the fact that the person's color has changed. So of course, as the blood is slowly going around the body, then the person begins to turn very pale. Their fingernails often go very blue. You can hear the very shallow breathing.
When somebody overdoses on opioid, there's a number of things somebody can do. I think the first thing is to call for help. So I think 911 would be the first place to call. And followed that, perhaps doing CPR, because these medications tend to shut down your respiratory system, so you have to give breaths. Even if you don't know how to do it, when you call 911, you can be coached on how to do it.
So very important to make sure that client, the person is still breathing. So we encourage everyone to do rescue breathing. It's not difficult. And certainly as we go forward with the rollout of the naloxone program, there will be training on how to do rescue breathing. And then if you do have naloxone, this is an opportunity to be able to administer the naloxone. It generally takes 1 to 3 minutes that you'll find a response.
So generally speaking, with a run-of-the-mill opiate overdose, a dose of naloxone or maybe a few doses of naloxone will awaken the patient, maybe put them into some opiate withdrawal. They'll be upset, but they won't be dead. The respiratory rate will come back. They may have some convulsions. They may have an acute opiate withdrawal syndrome with vomiting and sweating and runny nose and those sorts of things. But if we know that what we're treating is an opiate overdose, naloxone will reverse it if it's administered in time.
Now, if that response hasn't happened, within a few minutes, then it's important that you keep doing the rescue breathing. And if there's still no response, that you give another dose of naloxone. And by the time that sort of sequence has happened, hopefully the emergency services are there.
When you're dealing with fentanyl overdoses, it's a little bit more tricky because the typical doses that you use aren't effective, or they can last a very short time. So people often have to get more of the medication and for longer periods and require more monitoring as well.
The challenge with the illicit fentanyl that we're seeing, as we talked about, is that with the contaminants of other drugs, like xylazine, which is what we call an alpha-2 agonist, naloxone's not going to have any effect on that. And really, the important thing is if you've treated that person with naloxone, you still need them in hospital for supportive care.
And a lot of people think that sometimes if you overdose and just give a Narcan, everything is okay. And for the brief amount, it might be. But what can happen is that that second phase can occur as well. That's why people need to be monitored for a little bit longer time.
In any event, if you see somebody who looks like opiate overdose, you administer naloxone and then get them to hospital.
So it's part of our general intervention with our clients, or our engagement, both with our clients, the families of clients and the communities, is talking about safe use of drugs. So a harm reduction approach is basically meeting the client where they're at. So if they're still actively using, is trying to mitigate or to reduce the harms.
These would include things like using a very small amount, not combining multiple CNS depressants like alcohol or benzodiazepines with the fentanyl, or any opioids for that matter. I think being around other people so that if something should happen to you, that somebody can call for help. And hopefully you have people around who care about you who can do that. And of course, I think it's important to have, basic CPR skills if you have that. And also, if you can also have Narcan kits, I think that would be a good harm reduction strategy. It's not the only thing, but it's certainly something that could help.
Often there's a level of sensitivity around, do their families want me telling them that? Do their friends want me telling them that? Is it possible that that's going to be misinterpreted and seen as an endorsement of use, or an encouragement of use, or anything like that? When the reality is that we're looking first and foremost at public safety. We don't want people to die because of this. And then in the long term at supporting people throughout the course of their recovery. But we have to ensure their survival first to be able to support their recovery. In the case of a drug like fentanyl, we want a detailed and ongoing understanding of their relationship with their use, the routines of their use, the triggers to use, and to make sure that they have accurate information about the risks of use. So for example, the need to make sure that they use less should they relapse, or should they have a period of time away from use.
They may have been in drug treatment, they might have been incarcerated, they may just not have used for a while, and therefore obviously their tolerance to the drug has changed somewhat.
Those people who haven't used opiate for even days to weeks, their tolerance to opiates drops. And then if they take the same dosage, of course they don't know what that is, but if they take the same exposure, their risk or their susceptibility to overdose death is very, very high.
We know that injecting a drug is probably the most at-risk behavior.
If it's an injection drug user, you would obviously be concerned about the risks of bloodborne pathogens like HIV, hepatitis C. And for those individuals, safe needles, if they're not prepared for more definitive evidence-based treatment, is an important harm reduction strategy to offer. And if they're not into that, even outreach activities can be considered harm reduction, where it's just the simple provision of information about where you could go for screening for bloodborne pathogens or sexually transmitted infections, where you can go for housing information if they've started to experience social dysfunction from their opiate use, where to go for legal advice. Those types of things where you just reach out and offer them a way into the system is an important thing to do from the perspective of reducing harm.
You may not have all the answers or all the information, but it's very important that you be able to refer the client to a needle exchange, to an addiction counseling service, to a treatment center if that's what they're ready for. So it's having that information yourself and being able to have that conversation, having the confidence to have that conversation with clients.
Very often people who are struggling with addiction stop being treated like humans by the people around them because of the struggles that they're going through and the changes in their personality. And I think clinically it's very powerful to just ask, how are you doing? And try and peel the onion a bit to see if you can get them to reveal what's going on. The other thing that we talked about earlier is how hopeless people who are struggling with opiate dependency can feel because of the intrusive cravings and the withdrawal syndrome that they go through every single day and the desperation that they have for their next fix. And letting them know that help exists and that help can be effective and that most people recover from opiate dependency when they seek out treatment, again, is a very, very powerful message.
Ask the questions. Our clients are generally quite happy to tell you what's going on, providing that you're non-judgmental, that you're compassionate, that you understand that there are reasons that people use.
I think that our best role is to provide targeted help for the people who are directly impacted by fentanyl abuse, but also to recognize that this is a time when re-engaging in that kind of public conversation around substance abuse, the risks, the benefits of harm reduction, options for recovery, support, information. It's a time to re-engage people in all of those things.
So we have to use every opportunity for education, and it doesn't matter who the frontline worker is. It's always a good opportunity to have that conversation, to ask questions, and to educate.
By now we feel pretty confident that information doesn't lead to exploration. Information doesn't lead to experimentation. In this case, we're talking about goals of public safety, protecting the individuals concerned, and getting that message out as broadly as possible and as quickly as possible, but also the message of why would this be a difficult conversation for us to have in the first place? Let's use this difficult time as an opportunity to ensure that conversations around safer use of substances like fentanyl, whether under prescription or not, whether actually fentanyl or not, are conversations that we should be comfortable having. The people who are experiencing personal difficulties around substance abuse, the people who are losing family members to substance abuse, these are not strangers. These are our community within the province. And we want them to feel comfortable reaching out for help. We want people to feel comfortable reaching out to them.